Hello to all my dear lovely students. I hope all you are good and all you are doing well. So once again I welcome to all of you guys in this 25 most important MCQ series on MIST YouTube live channel. So I hope my audio video is good. So kindly message me if audio video is good so that we can start our session, guys. Good evening, guys. Good evening. Good evening to everyone. All lovely students, all future doctors, you all are preparing well for this upcoming FMGE exam. I hope so. Okay. So I hope everything is fine. So let's start this 25 most important physiology clinical questions series. Guys, before starting to this series, I would like to say to each and everyone that guys, right now you are having almost 1 month in your hands. In this 1 month, still you have enough time to prepare well, to revise well and to do lot of MCQs. Guys, first of all, don't be panic, don't be stressed. अभी घबराना नहीं है, अभी डरना नहीं है. आप जैसे पिछले इतने महीनों से जो मेहनत करते हुए आ रहे हैं उसी लेवल से और उसी पॉजिटिव माइंडसेट के साथ में आपको अभी भी मेहनत करनी है. आप बस अपने आप से रोजाना एक सवाल पूछेंगे कि दैट्स व्हाट इज़ द टुडेज टारगेट. इफ़ यू आर हैविंग दिस क्वेश्चन इन मॉर्निंग टू योर सेल्फ, in night when you are going to your bed, you just ask to yourself, have you achieved your target today? That's all. Don't think what is going to be happen on 26th of July. Just think what is going to be happen tomorrow or today evening. So let's make small that's targets, and then this small target one day will achieve a very big target. Right, guys? Okay. So let's start this 25 most important series. So as the session is going to be start, few words to all of you guys. This is something, the words which I actually find to all my lovely students, to my FMG aspirants, that you have trained your mind to be stronger than your emotions, or else you will lose yourself every time. Okay guys, तो इसी माइंडसेट के साथ में बस आपको लगे रहना है. यू कैन डू इट एंड यू आर गोइंग टू डू इट, राइट? सो लेट्स स्टार्ट द फर्स्ट क्वेश्चन इज ऑन स्क्रीन. लेट्स रीड द क्वेश्चन एंड ट्राई टू आंसर दिस क्वेश्चन. ए पेशेंट ऑन हाई एल्टीट्यूड ट्रैक डेवलप्स hyperventilation. ABG shows respiratory alkalosis. What is the primary stimulus? Yes, guys. Please try to answer. Yes, everybody. Yes, Vikas, dear, well done. Congratulations, you passed already. Yes. Yes, guys, all lovely students, please try to answer. Yes, भाइयों क्या आंसर होएगा इसका? हाँ जी. Yes. Very good, very good. All you are wonderful, guys. That's the right answer of this question is option number B, that is peripheral chemoreceptor detecting low PO2. Right, guys? As the question is saying, if we are going on the high altitude area, I told you in the class as well that at high altitude, due to that low partial pressure or low barometric pressure, we are not having that much of oxygen in the atmosphere, so that this lack of oxygen will induce inside that peripheral chemoreceptor. This peripheral chemoreceptor, it is situated in aortic and carotid areas, and this is nothing but this is your glomus cell, right guys? This is your glomus cell. So this peripheral chemoreceptor, this is actually your glomus cell, right guys? This is your glomus cell, and this glomus cell, it is having that potassium ATPase channel, which is oxygen sensitive, So this is the glomus cell which is situated into that's carotid and the aortic areas, and this is actually detecting the oxygen level in the blood. Now we all know that this is over heart, and this is over aorta. This aorta is having some sensors over here. भाई वो sensors जो बताएंगे कि what is the level of the oxygen in the blood. So these are the sensors over here. These sensors are called as aortic baroreceptor. But this aortic baroreceptor, actually this is for the baroreceptor for the BP. But similar fashion over here, there is aortic chemoreceptor as well. Chemoreceptors as well, and these chemoreceptors, they are situated in the aortic area. Similar fashion, there is at the carotid area. In this carotid area, at the carotid body, this carotid body, it is having that carotid chemoreceptor. Carotid chemoreceptor, right? So all these sensors which is situated into the aortic and the carotid areas, they actually fire whenever there will be the low level of the oxygen in the blood. Once they will be fired, this message will go into the medulla, and in the medulla it will increase the respiration. So respiratory rate is going to be increase. Guys, if the respiratory rate is going to be increase, which gas is going to be washed out? We know that is actually your CO2 gas. So CO2 will be washed out, will be there, and we know that CO2 gas, CO2 is the acidic gas. This is the acidic gas. So if CO2 washout will be there due to hyperventilation, what body will show? Body will show respiratory alkalosis, and this respiratory alkalosis actually will show that mountain sickness. So this will causes mountain sickness. Now who will tell me that's what is the drug of choice for the mountain sickness? What is the drug of choice for the mountain sickness? Yes, guys? Yes. So if at the respiratory level we are losing the acid, guys, our aim is to reduce the level, to increase the CO2 in the blood. This CO2 is actually continuously producing at the kidney level, at the nephron, at the PCT cell. So basically we just want to hold this CO2 in the PCT and want to mix into the blood. So from upside CO2 can be loose, but from the nephron level this CO2 can be mixed, and the drug that is for this is your acetazolamide. This is your carbonic anhydrase inhibitor drug, right? So this is your carbonic anhydrase inhibitor drug. So all you are wonderfully answered for this first question. Very good, guys, very good, lovely, guys. You are all having that's a very super preparation, like how you are answering I could see over here in the chat section. Guys, definitely all you are going to pass this exam, and definitely on the 26th of July you will come with your flying colors, right, guys? और इन सब चीज़ों के लिए like how you are answering, this is for all of you guys. जुनून होना चाहिए कामयाबी के लिए, सोच तो हर कोई लेता है, राइट? और आप लोगों ने ये ठाना है कि 26 जुलाई को पास होके ही आना है, राइट? वेल डन गाइस, वेल डन. Let's see the question number 2. The question number 2, read the question number 2, guys, and try to answer. Yes. A 32-year-old male presents with the progressive muscle weakness. Muscle biopsy shows a deficiency of a ryanodine receptor. So the first clue is your ryanodine receptor. So this is the first clue. First clue is the ryanodine receptor. Talking about that muscle. which step of the skeletal muscle contraction will be directly impaired? So if ryanodine receptor deficiency will be there, you should all know that's what is the function of the ryanodine receptor, guys. Ryanodine receptor is actually situated inside of the skeletal myocyte at sarcoplasmic reticulum area, right guys? Yes. So what is the right answer? Guys, read carefully. Read carefully. Again, I am telling you. No. This is how you should be answered. Read carefully the question first of all. Then please try to answer. Guys, question again. I am reading again the question. Question is saying 32-year-old male presents with the progressive muscle weakness. Muscle biopsy shows deficiency of a ryanodine receptor. Which step of skeletal muscle contraction will be directly impaired? It means if the ryanodine receptor is not functioning properly, what is going to be happen? You should know all the steps of from the neuromuscular junction up to the skeletal myocyte contraction, right? So guys, the first option is binding of calcium to troponin C, action potential propagation along sarcolemma. Option number C is release of acetylcholine at the neuromuscular junction, and option number D is detachment of myosin from the actin. Guys, I told you in the class that this is your skeletal myocyte. Remember this diagram? In this diagram, I told you that at the neuromuscular junction, that acetylcholine will be released. This acetylcholine once released, it will stimulate the action potential inside the muscle cell. And now this action potential will enter into which tubule? Into the T tubule. So it will go inside the T tubule. It will enter into the T tubule. It will activate the DHPR. DHPR stands for dihydropyridine receptor. This DHPR is mechanically attached with the ryanodine receptor. And this ryanodine receptor is like a gate. Gate for what? Gate for sarcoplasmic endoplasmic reticulum, which is actually your calcium warehouse. So where all the calcium of the muscle is actually stored inside the cell, this is your sarcoplasmic endoplasmic reticulum, and that is like a functioning like a gate for this area. So this ryanodine receptor ideally should be closed. Whenever DHPR will be activated due to this action potential at the T tubule, this ryanodine will be activated and it will be open. Once it will be open, due to the calcium concentration, this calcium will start moving outside, and this is going from higher side to lower side, will move passively without any energy, and now it will go to the upside, guys. This is your sarcomere, and in sarcomere we know this calcium will bind with what? Troponin C. Remember? So this troponin C will be activated, and this will remove the tropomyosin, and then the actin and myosin are going to be attached together, and then the firing of this myosin will lead to the muscle contraction. So guys, now question is saying if this receptor is not functioning properly, what could be happen to the next? Guys, after this receptor, what is the next step? This calcium will bind to the troponin C, right guys? So for now you can easily identify your answer. At neuromuscular junction, all this neuromuscular junction already done its job at the area where the nerve and the muscle are actually attaching together. After that, this action potential will be propagated up to T tubule into the DHPR. This DHPR activation will lead to the activation of ryanodine receptor, and then this ryanodine receptor will open up, will move the calcium outside, efflux, and activating the troponin C. So guys, I hope now nobody will forget this all step-by-step approach of this skeletal myocyte. Very important in prospect of your examination, right guys? Very good. So now after the muscle contraction is done, now what happens? Now that free calcium, because when the muscle contraction is done, action potential will be stopped, DHPR will be deactivated, this will be deactivated, but still the free calcium which is present outside, this need to be sent back inside of the sarcoplasmic endoplasmic reticulum. It need to be sent back, but we know outside little calcium, inside higher calcium. And if any substance moving from lower to higher, it requires the energy. So guys, now this process will be done via SARCA pump, which stands for sarcoplasmic endoplasmic reticulum calcium ATPase pump. One more thing, guys, if suppose this ryanodine receptor, which ideally should be closed and it should be open when the DHPR will give the message. Guys, please tell me, please remember, if this ryanodine receptor remain open, which condition that is? Which condition? Please answer, which condition? If this ryanodine receptor remain open, guys, what is that condition we called as? This pathological condition we called as, yes, malignant hyperthermia. Got it, guys? So that condition we called as malignant hyperthermia. Very good. Saeed, very good. Yes. So now, guys, you are answering absolutely right. Yes, Manasha, Mejut, everyone, you are perfectly answering, guys. Well done. Now, guys, one more thing you should remember about this part. So right answer of this question is binding of calcium to troponin C is going to be impaired. Guys, action potential propagation along sarcolemma, it's already done. It is already done, right? Then the T-tubule, it's get the T-tubule the current, then activating the DHPR. Release of acetylcholine at the NMJ, this is also done at the neuromuscular junction, and detachment of myosin from actin, guys, this will be happen only after once at this step is going to be happen, then this step is going to be happen. So the right answer of this question is option number A. Guys, also remember, this is your sarcolemma. In this sarcolemma, we know that this is your Z line, both the sides Z line, in between two Z line, one sarcolemma is there. And now inside of this sarcolemma, the red color area, this is your actin protein, and this blue color area, this is your myosin protein. We know actin is thin, myosin is thick. And now whenever the muscle is going to be contract, this myosin heads, they are going to be attached with the actin, and then it lead to the muscle contraction. Guys, what is going to be happen whenever the muscle contraction is going to be happen? For that, we should understand that all myosin containing area, this we called as A band. Which band? A band, and which always looks darker in the pathology or in the biopsy, darker on the microscope area. Now, where only the actin is situated, this we called as I band. And in between there is a line we called as M line, and where no actin is presented, or this free area, this we called as H zone. This free area completely, no actin, only myosin is remain, this area we called as H zone. So guys, now whenever the muscle contraction is going to be happen, what is going to be happen with different bands, you can see over here. You can see the size of sarcomere will be decreased. If the size of sarcomere will be decreased, Z line will be decreased or come closer. I band, which is also decreased, you can see over here, I band that much, and here it is only that much. So I band will be decreased. What about A band? Guys, A band remain constant because only the myosin head is moving. So A band is not going to be decreased or increase in the size. It will remain the constant. Now, what about the H zone? H zone can be decreased or it can be disappear. Now guys, please look at over here. If we will see in the microscopic slide, what are the different areas? Guys, here you can see this darker zone. This darker zone means this is your myosin area, and this line is your M line, and this dark line is your Z line, and this light area or light band you can see, this is your I band. So if this photo is going to be appear in your examination, guys, you should easily identify what are the different areas accordingly. Okay, so I hope everybody can now remember. Coming to the next question, the question number 3. Yes guys, please try to answer the question number 3. A patient with hypokalemia is noted to have muscle weakness. Which mechanism best explains decreased muscle excitability? Yes dear. Yes guys. So what is the right answer? Read the question and then try to answer. Yes. A patient with hypokalemia is noted to have muscle weakness. Which mechanism best explains decreased muscle excitability? Yes. Wonderful. Wonderful, guys. All you are. Some of you are beautifully answering, guys. Yes. Yes, 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 yes. The right answer of this question is hyperpolarization. Hyperpolarization of resting membrane potential. Guys, question is saying hypokalemia. The first clue is there is a hypokalemia. Hypokalemia means we are talking if this is the cell, and this is the blood vessel. Guys, we are talking that in this area there is a decreased potassium, isn't it? Hypokalemia doesn't mean that potassium inside the cell is less. No, because we are taking the sample from the blood vessel, and if we are checking the blood vessel, we are checking the level of potassium into this area, that is extracellular fluid area. And in this extracellular fluid, if potassium is decreased, guys, what will be happen? If potassium will be decreased, what will be happen? This inside potassium, when it is moving outside, due to this hypokalemia, when inside cell potassium will move outside during the repolarization area, this more potassium will move outside, and this lead to more negativity inside the cell. More negativity lead to inside the cell, and if cell is more negative, guys, we all know this is shows the less excitability. यानी कि सेल में उतना दम, उतनी जनरेशन पावर की नहीं हो पाएगी ड्यू टू द मोर नेगेटिव कंडीशन. राइट गाइस? सो दैट इज हाउ, that's right answer of this question is hyperpolarization of the resting membrane potential. We discussed this diagram in the class also. You remember that resting membrane potential is suppose -70. Initially at the up to the threshold level, initially the sodium channel will be open up. So in this area, that sodium influx will lead to what? Positivity inside the cell, and this phase we called as depolarization phase. Once it will reach into the positive side, means up to the +40 or the +30, guys, this is the sufficient current. अब current बन चुका है, and this current we called as action potential. This action potential where the cell will show some action, and then after cell wants to become again negative, and during the negative phase the potassium will move out, we called as a repolarization phase. Ideally, this repolarization phase should be stopped at the resting membrane potential condition, but due to the hyperpolarization condition, means when the cell comes at this level, guys, potassium channel which should be immediately closed, this potassium closure is going to be happen very slowly. So all the channel of the potassium, जो potassium के channel थे, वो धीरे धीरे बंद होते हैं. Ideally, they should be closed like फट अचानक से, तुरंत से, लेकिन all these potassium channel, they tends to close very slowly, and due to this closure, slow closure of this potassium channel, still some amount of the potassium is still getting out from the cell, leading to more negativity, and this phase we called as hyperpolarization phase. Right guys? Hyperpolarization phase. And then sodium potassium ATPase pump will be activate, and then it will again bring back into the resting state. So this is how actually your action potential is happens. Right guys? Now I found this image, and literally guys, I was that's smiling when I just saw this image, and really that's the thing actually mentioning in this image, that is pretty damn sure, that is true, that you can say ये सच्चाई है बेटा अपने लाइफ की, that when you balance your heart and mind equally, then you are the master of yourself. तो अपन कहते हैं ना कि ये तो सर मेरा दिल कहता है और ये मेरा दिमाग कहता है, तो बेटा the person who can make the balance between this दिल और दिमाग, guys, उसको रोकना मुमकिन नहीं, नामुमकिन है. और सारे FMG आप सब कान खोल के सुन लो, आपको रोकना मुमकिन ही नहीं, नामुमकिन है. नामुमकिन है मतलब नामुमकिन है. राइट गाइस? वेल डन. Coming to the next question. Read the question and try to answer. A researcher inhibits sodium potassium ATPase in a lab experiment. After a few minutes, absorption of glucose in the small intestine drops. What is the most direct cause of this reduced glucose absorption? Yes, guys, try to answer. Try to answer, guys. Yes, everybody. Yes, read carefully, guys. Read carefully the question and then try to answer. Then try to answer. सब कुछ सीधा नहीं होता है लाइफ में, सब घूम घूम के होता है, राइट? MCQ is also not direct. MCQ भी घूम घूम के आएगा. Question, what is the question is saying? Read the question carefully, first of all. A researcher inhibit the sodium potassium ATPase in lab experiment. Sodium potassium pump को block कर दिया है. After a few minutes, glucose absorption in small intestine decreases. What is the most direct cause? Guys, we know at the intestine level there is a channel for the glucose we called as SGLT1, isn't it? SGLT1. We all remember this part. SGLT stands for sodium glucose link transporter. Guys, now before I am telling to this answer, I just want to revise the mechanism behind this channel. Guys, just look at over here. Just look at over here. That this is suppose your intestinal lumen, right? So all the gulab jamun, whatever the gulab jamun you are eating, this gulab jamun is coming from this side, isn't it? इधर से आएगा. So suppose चलो अच्छा ये गुलाब जामुन आ गया, right? ये गुलाब जामुन जब आपका आया, now what will be happen? This gulab jamun when digested, this gulab jamun will release the glucose. Now this glucose need to enter inside this enterocyte, and from this enterocyte this glucose wants to enter into the blood. So we know this is your enterocyte, means the intestinal cell, and we know on this wall we called as a apical wall or apical surface, and on the blood side we called as a basal wall. We all know, guys, that on the apical surface there is a channel for the glucose absorption, and this channel we called as SGLT1 channel. SGLT1 channel. This SGLT1 stands for sodium glucose link transporter, means both sodium and glucose, when they will bind with this channel, then this channel will be open up, and then the sodium will move inside and glucose will move inside using the ATP, means this is a secondary active type of transportation. Secondary active type of transportation. Both are moving into same direction, so we call them sympoters. What we call this? Sympoters. Now, once this sodium will enter over here, guys, ये sodium अंदर तो नहीं रह सकता. This sodium should never remain inside. It means this sodium need to throw out from the cell. From which side? From the basal side. क्योंकि इधर से तो आपने लिया, तो आप इसको किधर निकालना चाहोगे? On the opposite side. And who is throwing this absorbed sodium from the cell into the from the basal wall into the blood, guys? This is actually done by sodium potassium ATPase pump. Remember, guys, Nokia. Remember, guys, Nokia about the sodium potassium ATPase pump. Sodium out, potassium in, using the ATP. So now the sodium which is absorbing from the intestine, due to this sodium potassium ATPase pump, it is getting out from here. So 3 sodium will move out, and in respect of 2 potassium will move in. Guys, suppose now if you will block this channel, or if you will block this pump, that's what the question is saying. What will be happen? Guys, the sodium which actually comes from this side into this area, this sodium can't able to move out from this area. And if sodium is not moving out, guys, sodium saturation will be increased, and now no more sodium can allow to come inside from this area. It means the absorption of this sodium will be decreased. So guys, now please tell me. Now please tell me what is the right answer of this question. Now please tell me. Yes. So what is the right answer of this question? Yes. Option number C. Collapse of sodium gradient across enterocyte membrane. That's the most appropriate answer. collapse of sodium gradient across enterocyte membrane. Right guys, because it is asking that why, what is happening actually when you are blocking this channel, sodium potassium ATPase pump, what is actually happening? Because if no sodium will able to come inside, if no sodium will move able to come inside guys, glucose also won't come, and if glucose will also not come, because this channel is not functioning. So that's the reason, that's why not A? Look at over here, why not A? Inhibition of the glucose transporter. See guys, over here, researcher inhibits sodium potassium ATPase in a lab experiment after, because question is saying already researchers blocked the sodium ATPase, sodium potassium ATPase it blocked. Now the examiner is asking what is the effect of blocking of this sodium potassium ATPase. That's why option number A is not right. Right? If the examiner was asking that what is the effect if you will block the GLUT, what is going to be happen, then you could answer accordingly. But as the examiner is already saying in the MCQ that this is blocking the sodium potassium ATPase pump, what is going to be happen, what is the mechanism behind that? So most appropriate answer will be the C. Right? Now coming to the next. Now please tell me guys, SGLT is two type. SGLT two type. This is SGLT1 and SGLT2. Guys, SGLT1 is situated into intestine and SGLT2 is situated into PCT, proximal convoluted tubule at nephron level or the kidney. Right guys, they both are secondary active. This SGLT is a type of secondary active transport, and then another channel for the glucose is GLUT, that is glucose transporter. This glucose transporter, they are GLUT 1, 2, 3, 4 and 5, so on, and they all are actually required the carrier protein. They require the carrier protein to function at the cell membrane, hence they are a type of facilitated diffusion or transport. They are a type of facilitated diffusion. Right guys, very important, very important. Right, now coming to the next question, question number 5. Read the question and then try to answer. A patient is infused with 1 liter of hypertonic saline, that is, question is saying hypertonic saline, that is 3% of sodium and chloride. Which of the following will most likely occur immediately after infusion? Which of the following will most likely occur immediately after infusion? Yes, now try to answer. Yes, well done. Yes guys. So क्या होगा जब आप हाइपरटोनिक सॉल्यूशन देंगे? 3 type of solution we studied, that is isotonic, hypertonic and hypotonic. So 0.9% is isotonic fluid, less than 0.9 hypotonic, more than 0.9 is hypertonic solution. So what will be happen if you will give the hypertonic solution? What is going to be happen on the cell? Yes. Yes guys. So giving the hypertonic solution means, suppose this is the cell, this is the blood vessel, and you are giving the hypertonic solution from here, means this is the 3% of solution, which contain what? Which contain sodium more, and this sodium will be present over here more. Now what is going to be happen? If more sodium is going to be happen, it means osmolarity of the plasma will be increase, right? Osmolarity of the plasma will be increase. So option number C saying decrease in plasma osmolarity, that is wrong. Then what about that increase in intracellular potassium concentration? No guys, it nothing related with the intracellular potassium concentration. Then decrease in intracellular fluid volume. Yes, of course. If more sodium will be present over here, to maintain the homeostasis by the cell, that cell will try to donate the water. Guys, this water will move outside. When this cell water will move outside to dilute this extra sodium or this high amount of the sodium, guys, what about the intracellular fluid volume? The intracellular fluid volume will be decreased. Swelling of the cell? No, guys. Swelling of the cell is actually happens in the hypertonic solution. Sorry, hypotonic, not in the hypotonic solution. Swelling of the cell is going to be happen. So right answer of this question is option number B, that is decrease in intracellular fluid volume. Right now we all know that's what is going to be happen by the different solution. If you will give in hypertonic solution, if you will give, what is going to be happen, you can see the cell will be shrinkage. In hypotonic, cell will be swell up and ultimately this swollen cell will be burst. And in isotonic solution, nothing impact is going to be happen on the cell, only the extracellular fluid is going to be increased. Right now Amal, actually initially question is asking most likely occur immediately. इमीडिएटली तो ऑस्मोलरिटी क्या हो रही है, इमीडिएटली ऑस्मोलरिटी बढ़ रही है, बट जब एक्स्ट्रा सेलुलर फ्लूइड बाहर आएगा तब वो ऑस्मोलरिटी डिक्रीज होगी. सो क्वेश्चन इज आस्किंग इमीडिएटली. तो पहला स्टेप क्या हुआ, प्लाज्मा ऑस्मोलरिटी बढ़ गई. दूसरा स्टेप क्या हुआ, दैट्स इंट्रासेलुलर फ्लूइड विल स्टार्ट कमिंग आउट. सो गाइस, यू ऑलवेज रिमेंबर in your examination you should identify always that most appropriate answer, isn't it? Might be you can think that sir A भी सही हो सकता है, B भी सही हो सकता है, but all the time you should answer most appropriate answer. So I hope Amul that's now that part is clear right now. So guys, one more quote, as this session is not only for that teaching session guys, this is also your boost up for the motivation as well. I just want to boost you, I just want to make you pass guys on this 26th of July. बस पास होना है. और आप सब लोगों के लिए कोई हालात को नहीं समझता, कोई जज्बात को नहीं समझता, ये तो बस अपनी अपनी समझ है. कोई कोरा कागज भी पढ़ लेता है तो कोई पूरी किताब भी नहीं समझता. राइट गाइज, वंडरफुल लाइन्स गाइज. यू ऑल आर गोइंग टू पास इन दिस एग्जामिनेशन. दैट्स आई रियली वंडर दैट्स इफ you could achieve more than 250 in your examination. Really guys, everybody says, बहुत सारे लोग मेरे पास आते हैं, वो मेरे से कहते हैं कि सर जून सेशन जो होता है थोड़ा सा टफ होता है सर, दैट्स in which direction we should be prepared, that's which part we should be more focused. Guys, I would say only the one thing to all of you. Guys, nothing is easy, nothing is hard until if you have decided that you are going to rock in this part. Guys, always remember, just read and study with this motto in your mind that अगर आप पास तो सब पास, और अगर आप पास नहीं तो कोई पास नहीं. If I will pass, then everybody will pass. If I will not pass, then nobody will pass. If you will study with this motto or if you will study with this mindset up guys, you will have full confidence in this 1 month of journey. तो बिल्कुल लास्ट समय चल रहा है guys, लास्ट पार्ट चल रहा है. You should continue your study and definitely you will rock in this examination. Now coming to the next question. Coming to the next, Alzheimer disease is early pathology, typically involves degeneration of the which area related to the memory? Yes guys, please answer. Alzheimer disease early pathology typically involves degeneration of which area related to memory? Yes. Alzheimer. Yes guys, please try to answer. Yes. कहाँ पे गड़बड़ होगी अल्जाइमर में? Well done guys, well done. Everybody. Wonderfully you are answering right. This is hippocampus. This is hippocampus. Hippocampus is the area where the short-term memory to long-term memory conversion is actually happens. This is actually the disease of the Gajini movie, जो गजनी के अंदर हुई थी. That's actually the area hippocampus, where all this damage is actually happens. So this problem in the Alzheimer is person not able to remember that long memory. Person can able to remember the short memory, but long memory loss is there. And now what about the prefrontal cortex, motor cortex and the occipital lobe? Guys, occipital we all know this is required for the vision. Motor cortex, which is actually situated into the frontal lobe, and in the frontal lobe different areas, motor cortex, frontal cortex and the prefrontal cortex. So this is also in the frontal lobe. This frontal lobe is actually required for the motor activity. So all the motor activity means that any initiation to do the functioning, everything you require, this is the job of the frontal lobe. Guys, in this prefrontal cortex, you require to take the decision. This gives you the decision memory or the decision power. That's what thing is you are going to be do, how you are going to be do. So this is all the job of the prefrontal cortex. Guys, we know that if anybody is having the lesion in the occipital area, there will be the vision loss. If anybody having the damage at the parietal lobe, this is actually the sensory lobe. So all the sensory sensation from the body, this will reach into the parietal lobe. So if the parietal lobe is going to be damaged, there will be the sensory loss. There will be the sensory loss will be there, right? There will be the sensory loss. Now, yes. Now, this hippocampus is the area for the limbic system. So this is the limbic system area. This is the limbic system area, and the limbic system which is also having some other areas like the amygdala. So guys, remember that prefrontal cortex, it is required for the planning, organization, time management, task initiation, working memory, metacognition, self-control, attention, preservance and the flexibility. Guys, in this frontal lobe, as you can see over here, that this is your motor cortex. Then this is your premotor cortex, which we studied in the class. That is the motor area, like Brodmann's area, like 6 or 8, and then this is the Brodmann's area number 4, and this is your prefrontal cortex over here. This is the Broca's area, and Broca's area for what? Yes, you all remember the Broca's area for that motor speech. This is for the motor speech. This Broca's area if going to be damaged, what is going to be happen? There will be the motor aphasia will be happen. Motor aphasia will be happen, which is also known as non-fluent aphasia. Non-fluent aphasia. My question to all of you guys, what is the sensory speech area? Yes, please answer. What is the sensory speech area? Sensory speech area. Which is the sensory speech area? Please try to answer. Yes. Sensory speech area is Wernicke's area. Yes. Wernicke's area, which is situated into, yes, which lobe? Wernicke's area. Which lobe this is? Temporal lobe. So this is situated at the temporal lobe, and if this Wernicke's area is going to be damaged, yes, if it is going to be damaged, guys, this we called as sensory aphasia, also known as fluent aphasia. It means person can speak but he can't able to listen. So this is how the different aphasia condition is there. I hope now everybody can remember. Okay. Now this motor cortex, which is required for that different type of highest level motor functioning, like precise skillful intention movements controlled by the primary and this premotor and supplementary motor area, and then this limbic system. Guys, limbic system, that is having the different organs inside of this area, and this limbic system is having hypothalamus, olfactory cortex, mammillary bodies and the amygdala. Most important which you have to remember, hippocampus and the amygdala. Right guys? Right. So these two things you have to be understand and you have to remember. If amygdala is going to be damaged, this is lead to Clever-Bussy syndrome. Clever-Bussy syndrome. So this is actually the lesion if in the amygdala is going to be happen. Clever-Bussy syndrome. Coming to the next question. Question number 7. Yes. Question number 7. Yes, guys. A patient with chronic obstructive pulmonary disease (COPD) has a pH of 7.32, PCO2 60, and bicarbonate is 31. What is the most likely primary disorder and the compensation? Yes, guys. Yes, everybody should answer correctly. Yes, ABG. You all are master of ABG, isn't it? ABG तो अपना है, ABG को ऊपर नहीं छोड़ सकते हैं, right? ABG तो जिंदगी भर के लिए याद हो गया. Lifelong, you will never forget the ABG. I hope so, right, guys? How we studied in the class, I can bet that nobody can forget this ABG. What you need to do? Only you need to identify the culprit. Yes, well done, guys. Well done. Beautifully, you are all answering. Yes. Yes, beautifully. Well done, guys. Salute to each and everyone. How beautifully. जिस ABG से अपने को सदा डर लगता था, now this ABG सदा के लिए अपनी हो गई. Right? So this is how, guys. If you will show your intention to read anything, to learn anything, you can learn all the things. Right now. So right answer of this question as absolutely how you all are telling, yes, this is respiratory acidosis with renal compensation, right? So please look at over here. Please look at over here. That's what is the step-by-step approach to always solve the ABG questions. First of all, write down the pH, then see the CO2 and the bicarbonate. We know CO2 property is acid, bicarbonate property is alkaline. Isn't it? If we talk about the normal value, that normal pH is 7.35 to 7.45. Normal CO2 level is 35 to 45 and normal bicarbonate level is 22 to 28. It means if pH is going less than 7.35, this is towards the acidosis. And if pH is going more than 7.45, this is going towards the alkalosis. If CO2 is more than 45, it is leading to acidosis because property of the CO2 is acidic, यानी कि body में acid ज़्यादा हो रहा है. And if it is going to be decreased, it leads to alkaline. Bicarbonate if increase, it lead to alkaline, and if it is decreased, it lead to acidic condition. Now, whenever pH is going to be disturbed, this pH could be disturbed with only two components, either due to CO2 or either due to bicarbonate. What you need to do? In such ABGs, you just need to identify the culprit. Who is the culprit? And now, guys, how you can identify? You can identify. In this question, what is the value is given? Now, please check the value. The value is pH is 7.32, CO2 is 60 and bicarbonate is 31. Now please identify who is the culprit. We know what is the condition of the pH. pH towards the acidic side. So this is acidosis. Now CO2 is normal, high, low, that is high. High means this is also acidosis. Bicarbonate is normal, high, low, that is high. High means alkaline because property of the bicarbonate is alkaline. So this leading to alkalosis. So guys, you can see what is happening with the pH. pH is towards going to the acid side, and who is the culprit? Culprit is your CO2. Culprit is your CO2. So CO2 increasing its level, that's why pH is disturbing. Hence we call this is respiratory acidosis. For bicarbonate we use the word metabolic, for CO2 we use the word respiratory. And with why this bicarbonate is actually changing its value, it want to compensate, it want to bring back this pH into the normal condition. So this is the compensation, and bicarbonate is compensated by the renal, by the kidney. So guys, this is actually respiratory acidosis with partially compensated metabolic alkalosis. So if examiner is not written over here partially compensated metabolic alkalosis, then guys what examiner mentioned, respiratory acidosis with renal compensation. तो इसने पूरे को मिला के उसने क्या लिख दिया, renal compensation. So this is how you can easily identify what is the right answer, respiratory acidosis with renal compensation, right? So please remember that's pH. This table is going to be help you a lot, right? This is how what I actually explained, this is mentioning into this table, right? Now, Madhuri, because property of the CO2 is acidic, na? So CO2 gas is acid. So what CO2 is going to be increased, what it does it mean? It means that acid is increasing inside the body. So if more CO2 is there, means body is going towards the acidic side. So that's why we identify this is the acidosis, right? Now, coming to the next question, a 25-year-old athlete suddenly stands up after lying down for hours. What immediate autonomic change maintains blood pressure? Yes. Please try to answer. Yes, guys. Yes, please answer. Yes, guys, try to answer for this question. Question number 8. A 25-year-old athlete suddenly stands up after lying down for hours. What immediate autonomic change maintains the blood pressure? The person was lying down, gravity was decreased. Person stands up, gravity increase. Right? Right? Now, what immediate autonomic changes maintain the blood pressure? If person stands up, due to the gravity, more blood towards the downside. Now, this lead to less blood will reach into the heart. Heart will decrease the pump, decrease in the pumping of the blood, and decrease the cardiac output, will leading to decrease in the BP. Guys, who will detect this? Yes. Yes. Yes, everybody. Yes, guys, everybody perfectly you are answering. So as you can see over here, if the person was lying down earlier, gravity was neutral. Now when the person stands up, due to the gravity, more blood you can see downside at the area in the lower limbs. Now what is going to be happen, that this heart will receive less amount of the blood, and if heart will receive the less amount of the blood, less cardiac output will be there. Now less cardiac output will decrease the BP. Now the baroreceptor is there. They will stop the firing, and if baroreceptor firing will be stopped, guys, this stopping or inhibition of the baroreceptor will ultimately immediately activate the sympathetic system, and this sympathetic system will ultimately increase the heart rate and will do the vasoconstriction. So you can see over here that standing lead to venous pulling and capillary filtration. Then central blood volume will be decreased, stroke volume will be decreased, cardiac output will be decreased, and this lead to what? This lead to increase the heart rate and vasoconstriction, to increase the BP. क्योंकि जब अपन पाइप को दबाएंगे प्रेशर बढ़ेगा, if vessel is going to be dilate, pipe dilate होगा तो BP कम होगा. So this is how basically increase the sympathetic discharge to the SA node and the arterioles. SA node discharge will increase the heart rate, and arterioles will lead to vasoconstriction. So this is the right answer of this question. Option number C. Right? Increase parasympathetic discharge to the heart, it will decrease the heart rate. If decreasing the heart rate, it will further decrease the BP. Decrease sympathetic discharge to the arterioles? No, guys, it should be increased. Arterioles, if getting the sympathetic stimulation, there will be vasoconstriction, right? Decrease norepinephrine release at the cardiac muscle? No, guys, it should be increased, because the neurotransmitter of the sympathetic discharge will be the norepinephrine, right? So this should be increased now, right? Okay. Now again, जीने का बस यही अंदाज रखो, जो तुम्हें ना समझे उसे नजरअंदाज करो. राइट। और यही काम आपको एग्जाम में भी करना है। जो क्वेश्चन आए उसको अच्छे से करो, और जो क्वेश्चन ना समझ आए, नो नीड टू बी पैनिक, नो नीड टू बी स्ट्रेस, नो नीड टू टेक एनी स्ट्रेस, टेंशन, नथिंग। जो नहीं समझ आए उसको नज़रअंदाज करो, और जो समझ में आ जाए उसका मजा लो, राइट। सो दिस इज हाउ यू शुड बी अपीयर इन द एग्जामिनेशन। कमिंग टू क्वेश्चन नंबर 9. Yes. Question number 9, please try to answer. Which JVP component corresponds to isovolumetric contraction of the right ventricle? Which JVP component corresponds to isovolumetric contraction of the right ventricle? Yes, guys. Yes. Absolutely, all you are right. Right answer of this question is C wave, that is isovolumetric contraction. Guys, we know that if suppose this is your heart, we know this is the right atria, left atria, right ventricle and the left ventricle. In the JVP, we are checking that pressure into which area? Into the right atria. So guys, in which condition right atrial pressure will be increased? Right atrial pressure will be increased. So guys, please pay attention. Whenever this blood will enter, or the central venous blood will be enter into the right atria pressure will be increased. Where the right atria will be contract, right atria pressure will be increased. So wave will go to the upside, right? Whenever the blood will drops down into this area, that's right atria pressure will be decreased and wave will go downside. Whenever the right atria will be relaxed, that right atria pressure will be decreased and again the wave will go downside. So guys, you can see whenever we are talking about the JVP is having different waves. The waves are over here like the A wave, C wave, V wave and then X and the Y wave. Guys, 3 wave is showing the increase in pressure in the right atria, and 2 waves which is coming to the downside, they are showing the down or the negative pressure into the atria. So what is going to be happen? Whenever we are talking about the A wave, the cycle starts from the A wave. This A wave means when the third cycle or that third step of blood is going downside into that ventricle. And whenever the blood is going from the atria into the ventricle, guys, at the third step, what is happening to the atria? I told you atria was contracting. 3 step में blood atria से ventricle में आ रहा था. The first 2/3 blood, it comes passively without any contraction of the atria. It is due to the gravity. Last 1/3 blood, it comes due to the contraction of the atria, and this requires the energy we call as active ventricular filling. Guys, now in the JVP, we are starting from this phase. When the active ventricular filling is happening, atria is contracting. When the atria is contracting, we know the pressure will be increased, hence the A wave will be shown in the JVP. Now, when all blood goes down from this atria into the ventricle, now what is going to be happen into the ventricle? This ventricle, this valve is closed, and now this tricuspid valve will also be closed because all complete ventricular filling is now done. Now this ventricle is become a closed chamber. This ventricle, when become the closed chamber, during this time, this will start the contracting. Due to this contraction, when both valves are closed, none of the volume of blood will move out or in, and that's why this phase of this phase of the contraction of this ventricle we called as isovolumetric contraction. Iso means same volume contraction, and due to this isovolumetric contraction, severely pressure increased into this ventricle, and due to this condition, this pressure will put the pressure on the above valve. This valve we called as tricuspid valve. This tricuspid valve will be bulged like this, and due to this bulging, again the right atrial pressure slightly will be increased. Okay guys, and due to this condition, that's what the question is actually asking. Which JVP component correspond to isovolumetric contraction phase of the right ventricle? Answer of this question is C wave, right guys, C wave. Now what will be happen after that? This ejection will start from this ventricle. This bulging will also be come down. Atria will also be relaxed. So what is going to be happen? Due to this condition, pressure will be decreased. Hence, you will see the X wave. You will see the X wave. Then the blood will start coming again into this right atria. Filling will be occurs. When the 2/3 filling will be occur, again the pressure will be increased, and this will show the V wave. And when this 2/3 blood will fall down into the ventricle, again the right atrial pressure will be decreased. This will show what? The Y wave. What it will show? The Y wave. So this is how the different waves are there. Few pathological waves are there, like absent A waves is seen in atrial fibrillation. Large A wave is seen in pulmonary hypertension or pulmonary stenosis. Cannon A wave, this will seen in complete heart block, which is also called as third degree heart block, which is also called as third degree heart block, third degree heart block. Also seen in ventricular arrhythmia. Large V wave, this is seen in tricuspid regurgitation, very important. And rise JVP during inspiration, that's we call as Kussmaul sign, which could be seen in constructive pericarditis. So ideally during the inspiration, that's lungs area and the cardiac area is expand. Ideally the pressure should be decreased and JVP should be decreased. But during the inspiration, if we identified JVP still increase, guys, this condition we called as Kussmaul sign. Kussmaul sign. Don't be confused with the Kussmaul breathing, which seen in the DKA, diabetic ketoacidosis, which is hyperpnea and the tachypnea, fast and the rapid breathing, means the rapid, or you can say the shallow breathing, right? That we called as Kussmaul breathing, which seen in DKA, but the Kussmaul sign that seen in the constructive pericarditis related to the heart, right? Related to the heart. Now, coming to the next question, which of the following is true regarding the baroreceptor reflex? Which of the following is true regarding the baroreceptor reflex? Yes, giant or large, same. Yes, guys, please try to answer. Which of the following is true regarding the baroreceptor reflex? Baroreceptor reflex, as we have already discussed about this part, baroreceptor, two type of baroreceptors, central baroreceptor and the peripheral baroreceptor. Peripheral baroreceptor is situated into aorta and the carotid artery, and the central baroreceptor is situated into the medulla, right? Right. So what is the true? What is the function of the baroreceptor? Yes. Guys, please answer carefully. First of all, tell me, what about that long-term control of the blood pressure? Guys, long-term control of the blood pressure done by the kidney. This is by the RAS, renin-angiotensin-aldosterone system. So this is not true about this part. It helps buffer acute changes in the blood pressure. Okay. Increased baroreceptor firing causes vasoconstriction. Guys, voice is not clear. Now voice is okay. Guys, tell me now voice is okay. Yes, I hope now audio is good. Right. Now, guys, long-term control of the blood pressure will be done by the kidney due to the RAS. So this is not the true statement. Now talking about option number A, carotid baroreceptor sends afferent via vagus nerve. Guys, carotid is situated over here, aorta is situated over here, vagus is the longest cranial nerve. So ideally vagus should take the aortic baroreceptor message, not the carotid. Carotid is nearby to the tongue. So this is taken by the glossopharyngeal, not by the vagus. So again, this is not by the vagus, this is by the glossopharyngeal, right? Now, two option is left. increased baroreceptor firing causes vasoconstriction, and option number C, it helps buffer acute changes in blood pressure. Yes guys. Now sir, दो तो rule out हो जाते हैं, two options easily rule out. Now we always distract between the two options, right? B or C. Guys, first you should understand, baroreceptor whenever fires, it want to decrease the BP. Whenever the baroreceptor will fire, it want to decrease the BP, right guys? So suppose if baroreceptor is firing, it means BP is high, and this baroreceptor wants to decrease the BP. So what this baroreceptor will do? This baroreceptor will immediately activate cardioinhibitory center, and this cardioinhibitory center will activate parasympathetic. Guys, now please tell me, if the parasympathetic activation will be there, what is going to be happen? Vasodilation or vasoconstriction? Vasoconstriction or vasodilation? What is going to be happen? Guys, heart rate will be decreased and vasodilation will be there. So now guys, please answer. Increased baroreceptor firing causes vasoconstriction. No, this is lead to vasodilation. जब भी बीपी कम होता है तो baroreceptor बिल्कुल फायर नहीं करते हैं, and whenever the baroreceptor is not firing, sympathetic activation will be there. But whenever baroreceptor will be firing, vasoconstriction is not going to be happen, vasodilation is going to be happen, because parasympathetic activation will be there. That's the reason. Guys, whenever any soldier press over here, after some time, if you press over here, you are pressing the carotid baroreceptor. This carotid baroreceptor sense that pressure is high, they will send the message to the brain, and brain will immediately decrease the heart rate, decrease the cardiac output, less blood will reach into the brain, and person become immediately unconscious or the faint. So that's the reason behind it. Pressing over here, person can become unconscious, right? So right answer of this question is option number C. So this is how guys you should be very much careful in your examination on the 26th of July. Now, so you can see over here baroreceptor reflex, that's carotid via glossopharyngeal nerve, this is via glossopharyngeal, this is via vagus nerve, right guys, vagus nerve. Coming question number next, question number 11. Which of the following tissue express GLUT4 as the primary glucose transporter? Which of the following tissues express GLUT4 as the primary glucose transporter? Yes, guys. Yes. Yes, answer for this question number 11. Yes, easy question. Right? Well done. Well done. Yes, right answer of this question is skeletal muscle, skeletal, adipose tissue, and also the cardiac muscle, right? So three areas where the GLUT4 is actually found: skeletal muscle, adipose tissue, cardiac muscle. And remember guys, this GLUT4, this is always insulin dependent. This is only the GLUT which require the insulin to open up. So if no insulin is there, GLUT4 will remain closed. So this is always the single GLUT which actually require the insulin to open up, right now. So this is the GLUT4, and again I told you the GLUT, it is a type of facilitate transport. Facilitate transport means no energy is required. This is the passive transport, right? Passive transport. So some other GLUTs, that is your GLUT1, GLUT2, GLUT3 and the GLUT5. We know GLUT1 in blood, BBB, blood-brain barrier and the heart, GLUT2 in the liver, pancreas, small intestine, GLUT3 in brain, neurons and the sperm, and the GLUT5. This is for the fructose. Remember guys, this is for the fructose, and this is also non-insulin dependent. Non-insulin dependent, right? So all this GLUT1, 2, 3, they are insulin independent, and also the GLUT5, but GLUT4 is insulin dependent. This is insulin dependent, right? Now, So till now, I hope guys, all you are wonderfully answering and all you are enjoying this session. शायद कुछ ऐसे क्वेश्चन आए होंगे जो अभी तक आपने पढ़े होंगे, लेकिन somehow some confusions are there, guys. Actually, this session I made something like that similar type of terminology or the language that's all the time in the recent examination is actually asking. So you should be able to identify the proper language of the question. Once you will able to identify, आपको अगर क्वेश्चन की लैंग्वेज समझ में आ गई तो guys you can easily answer for this MCQs, right? Now the one thing that's quote for all my lovely FMG students, समय की कीमत अखबार से पूछो, सुबह की चाय के साथ आता है और शाम की चाय तक रद्दी हो जाता है। इसलिए जिंदगी में जो करना है समय पे कर लो, क्योंकि जिंदगी मौके कम और अफसोस ज़्यादा देती है। इसलिए बेटा जो सोच रखा है उसको पहले करना है। जो भी आपको लाइफ में आगे करना है, चाहे आपको डॉक्टरी करनी है नहीं करनी है, डजंट मैटर, but already you spend 5 years, 6 years in your respective universities, respective countries. Guys, show the courage that you done this degree or you done this diploma not only for nothing, you done this for something. आपको एग्जाम पास करके you should get the license. Then after whatever profession you will choose, that's depend upon the individual, but the one thing will always remain with you, that's Dr. dot will always be there just before of your name and nobody can wipe this out. So guys, always remember, ऐसा नहीं करना है कि सर हमसे अब पढ़ा नहीं जा रहा है, हमसे अब इतनी मेहनत और नहीं होती है बेटा, क्योंकि जो मेहनत करता है बेटा विजेता उसी को कहा जाता है, राइट? So you all are having the courtesy, you will come with the flying colors, just stay positive and keep studying, right? Coming to the next, the destruction. Now coming to the next question is, destruction of the lateral hypothalamic area leads to which of the following? Yes. Destruction of the lateral hypothalamic area leads to which of the following? Hyperphagia, hypothermia, anorexia and the polydipsia. Yes. Try to answer. Very good. Well done, guys. Right answer of this question is anorexia. Some areas in the hypothalamus are different. Hypothalamus lesion are different. That is like the suprachiasmatic nucleus. Suprachiasmatic nucleus, that is related with the circadian rhythm. I told you that suprachiasmatic nucleus related with the circadian rhythm. Then supraoptic and the paraventricular. Remember guys, SOAP. Remember the mnemonic SOAP. Supraoptic for ADH and paraventricular for oxytocin, right? So supraoptic for the ADH and paraventricular for the oxytocin. Oxytocin is required for the milk ejection and the ADH is required for the water reabsorption or the water conservation. They both are released from the posterior pituitary, right? Lateral hypothalamic, it increase the feeding, and ventromedial, it decrease the feeding. Lateral increase and ventromedial decrease. If question is asking, if the lateral hypothalamic area is damaged, what is going to be happen? The person will have decrease in feeding. वो कम खाएगा, उसको भूख ही नहीं लगेगी. So that is how this condition we called as anorexia. Anorexia means less eating. So right answer, if the lateral hypothalamic area is going to be damaged, person will show the anorexia. Guys, hyperphagia किस condition में? Now please tell me, hyperphagia, when the person will show the hyperphagia? Hyperphagia when the person will have the problem in the ventromedial area. When the ventromedial area is going to be damaged, this can lead to hyperphagia, right? Hypothermia and hyperthermia, this is anterior and the posterior hypothalamus area. So if there is a damage, this condition is going to be happen. So this is how the different condition is actually happens. Okay. Now polydipsia when the supraoptic nucleus, right? Supraoptic nucleus This is for related to the ADH. So if ADH is not there, what is going to be happen? Water loss will be happen, diabetes insipidus, and person will have that increase in thrust we called as polydipsia, right? Polydipsia, right? Now, coming to the next question, what is the correct function of the aquaporin 2 in ADH action? What is the correct function of the aquaporin 2 in the ADH action? Yes. Please tell me what is the correct function of aquaporin 2 in the ADH action? Yes, guys. So we know ADH is actually act via V1 and the V2 receptor. V1 and the V2 receptor, V1 receptor at the vessels and V2 receptor at the collecting duct in the nephron, collecting duct of nephron. And now what this aquaporin 2, this aquaporin 2 is situated into that collecting duct, right guys? So now what is going to be happen? This transport, this, now please answer me. Yes guys, what is ADH will do? Transport of sodium and water in proximal tubule? No guys. Insert into apical membrane of the collecting duct, reabsorb urea from the medullary collecting duct. Guys, yes, it could be, blocks potassium excretion in the distal nephron. No, this is the function of aldosterone, right? This is not the job. This is diuretics which blocks the potassium excretion in the distal nephron. Or you can say that this is some diuretic drug which we can give, then only the action will be happen. So now we remain with the two options, B and C. Guys, the better choice in this option, that's insert into apical membrane of the collecting duct. If you are having such type of two options, the better choice I would mark, that is option number B. Reabsorb urea from the medullary collecting duct? No guys, this is not only from this area, this certain area in that's PCT area is also urea reabsorption will be there, and then in another area will be there. So better choice is the B. So we know that in hypothalamus that posterior pituitary is releasing the ADH, or this ADH we called as what? This ADH we also called as vasopressin. This will act on the V1 receptor on the blood vessel, V2 receptor in the kidney. V1 receptor, that's V1 receptor functioning will lead to what? Vasoconstriction, and V2 receptor will lead to what? Increase reabsorption of the water and increase blood pressure, right? Increase the blood pressure. And here you can see, very important part guys. You can see over here that this is the collecting duct lumen, and this is your blood vessel, right? This is your blood vessel. Now guys, we know this is the cell, collecting duct cell. Now this is the basolateral side and this is the apical side. On apical side there is the aquaporin 2 channel, there is present. Now whenever the ADH will come from the blood, this ADH will act via V2 receptor. This is the V2 receptor for the vasopressin, and then this V2 receptor will give the message to which area? It will give the message to the nucleus. What is the secondary messenger? The secondary messenger is cyclic AMP. Very, very important. What is the secondary messenger for this V2 receptor? That is cyclic AMP, CAMP, right? This will give the message to the nucleus. Nucleus ultimately will open the aquaporin 2 and the water will start reabsorbing inside of the cell, and then ultimately will go into the blood. This we call as facultative reabsorption. Right guys? So this is how all this condition is actually happens. Please tell me, if ADH is less, if ADH is decrease, what is going to be happen? This lead to what? This lead to diabetes insipidus, and if ADH is excessively high, this condition we called as SIADH, syndrome of inappropriate antidiuretic hormone. Right guys, remember, so two pathological condition in the ADH, diabetes insipidus when less ADH or the receptor is damaged, and the SiADH is due to that excessive ADH secretion will be there, right? Now coming to the next question, number 14. Which of the following EEG waves is most associated with the relaxed and awake state with eye closed? With eye closed. Yes. Right, guys? Now please answer. Amal, that's lateral perioptic for the thirst. Supraoptic nucleus is this basically for the ADH, and suprachiasmatic, that is for that circadian rhythm. Now, yes, everybody is right. Everybody is right. EEG waves, guys, person is awake and eye is closed. Right answer is alpha waves, right? So I told you in the class that when we are having the open eyes and we are just sitting, when the eyes are open and we are relaxed, then if we'll put the electrode over here, we will see the beta wave. If we just close the eyes, we are not sleeping, just simply we close the eyes, then if I'll put the electrode over here, this time the wave which I will see little lesser, that we call as alpha wave. When you are highly focused during the 26th of July, if at 10 p.m. I will put the electrode on your head, guys, you are highly focused, आपके दिमाग उथल पुथल चल रही होगी, all the 19 subjects. This time the waves of your brain will be very higher waves. This we call as gamma waves. When you are in the light sleep, you will show the theta wave, and when you are in the deep sleep, you will show the delta wave. So always remember, one more time, highly focused, gamma wave. Eyes are open, you are awake, beta wave. Eyes are closed, you are awake, alpha wave. Light sleep, theta wave, and the deep sleep, delta wave, right? Deep sleep, delta wave. Now, so right answer of this question is alpha wave. So you can see over here that gamma waves, very high frequency cell, very high frequency wave, you can see. Then beta wave, little less, alpha wave, more less, theta wave, more less, and delta wave, very less frequency, right? So this is how the frequency is also mentioned over here. So now there are two type of sleep conditions are there, that REM sleep and the NREM sleep. We know that rapid eye movement and non-rapid eye movement sleep. Guys, we know that biggest sleep cycle, that is the NREM, and NREM is further divided into NREM 1, NREM 2 and NREM 3. Out of that, NREM 2 will be the biggest. Now this during the non-rapid eye movement sleep or the NREM sleep, guys, there will be no eye movement or very slow movement will be happen, but during the REM sleep there will be the rapid eye movement will be there. Now the body movement, in the REM the muscle twitches will be there, and in NREM muscle completely will be relaxed. Vital signs fluctuating in the REM, heart rate can be increased, can be decreased, but in NREM there will be stable vitals are there. Muscle tone will be decreased in REM, and some tone in the postural muscle will be there in NREM. Then pillar erection will be common in REM, and NREM shows the rare condition. REM sleeps more in the morning, and whatever dreams you will see, you will remember. So in NREM, dream you will remember. Dream you will remember. Dream you will remember. And here, not remember. So whatever dream you will see, you will not able to remember in NREM. Right, guys? So this is how that you can differentiate between REM and the NREM sleep cycle. Now, जल को बर्फ बदलने में वक्त लगता है, सूरज को निकलने में वक्त लगता है, किस्मत को तो हम बदल नहीं सकते, लेकिन अपने हौसलों से किस्मत बदलने में वक्त लगता है, और वो किस्मत बदलने वाला दिन है 26th ऑफ जुलाई 2025। 26 ऑफ जुलाई 2025 आपकी किस्मत बदलने जा रही है, आपका वक्त आने वाला है, आपके लिए सूरज निकलने वाला है और उगता सूरज आपको सलाम करने वाला है। वेल डन गाइस। कमिंग टू द नेक्स्ट, द बेन ब्रिज रिफ्लेक्स इज characterized by which of the following changes? Yes, the Bain bridge reflex is characterized by which of the following changes? Now please answer for the question number 15. Yes guys. Bain bridge reflex. Three reflex we studied in the heart: Bain bridge, Basal gyrus, and the Cushing reflex. Remember? Yes guys. So Bain bridge reflex. Tell me the one reflex I told you for the right atria, another reflex I told you for the left ventricle. Guys, left ventricle, that is Basal gyrus, and right atria, that is Bain bridge. Right, Bain bridge reflex. Yes. Yes, everybody correctly answered, everybody answering wonderfully. So we know that this is the heart. This is the heart. The one reflex for this area, another reflex is for this area, right? This reflex we called as Basal gyrus reflex, Basal gyrus reflex, and this we called as Bain bridge reflex. Whenever this reflex will be activate, this will activate when the venous return will be increased. जब इसमें ज़्यादा blood आएगा, when the more blood will come into this area, what this chamber wants to do? This chamber wants to very fastly pump this blood out from this area, and this blood should only move into this direction. So basically this right atria will immediately send the message to the brain, and brain will immediately increase the heart rate. So what is going to be happen? This message lead to increase in heart rate, right? And increasing in heart rate lead to what? Increasing in the BP. So that is how the Bain bridge reflex will lead to increase in heart rate. Now the Basal gyrus reflex, this is seen during the MI condition, or whenever there is a decrease in preload. Whenever there is a decrease in preload or the MI condition, this Basal gyrus reflex, this will give the message to the brain, and now the brain will give the message via initiation of the parasympathetic, so heart rate will be decrease. So that's why Bain bridge reflex we called as tachycardiac reflex. This is also called as tachycardiac reflex, also called as atrial reflex, because releasing starting from the atria, and Basal gyrus we called as bradycardiac reflex, right? So you can see it will increase the heart rate, it will increase the BP, and this will decrease the heart rate, this will decrease the BP. So that is how the Bain bridge and the Basal gyrus reflex are there. Right guys, so right answer of this question, now you can see the Bain bridge reflex, that's characterized by which of the following changes? Bradycardia? No guys, no bradycardia. There is a tachycardia. Tachycardia in response to increase the venous return? Yes. Hypotension? No. And reflex bradycardia? No. So this is the tachycardia in response to increase the venous return. Right now the Cushing reflex, one more thing. Cushing reflex, it's seen during the high intracranial pressure. In this high intracranial pressure, there is a, what is going to be happen? Cerebral ischemia, and this cerebral ischemia will give the message to increase the heart rate, and this increase the heart rate will lead to increase the BP. This high BP will immediately detect by the baroreceptor, and they will decrease the heart rate. So what is happening in the Cushing reflex? In the Cushing reflex, there could be seen hypertension, bradycardia, and there is a irregular breathing. Irregular breathing we called as Cushing triad. We called as Cushing triad, right? So in Basal-Jarris, decrease BP, decrease heart rate. In Bainbridge, increase heart rate, increase BP. In Cushing reflex, decrease heart rate and the increase BP. Coming to the next, the Basal-Jarris. Now you can easily answer. The Basal-Jarris reflex leads to which of the following physiological response? So we know Basal-Jarris will decrease the heart rate and it will lead to decrease the BP. So guys, you can see over here that this is decreasing the heart rate and the hypotension and the apnea can be there, right? So right answer of this question is bradycardia, hypotension. No tachycardia, no hypertension, no heart rate will be increased right now. Now, the one thing you should be remember from the nephron, guys, this diagram I especially put over here so that in this one single diagram, complete renal you can easily remember, right? So let's start from this part. In this part you can see that this is your glomerulus, this is your Bowman capsule. Guys, from the glomerulus, whenever the filtration is going to be happen, this we called as a GFR, and GFR is 125 ml per minute for the both kidneys, right? When this area releases that the filtrate area into this Bowman capsule, there is the two substance glucose and amino acid. This is 100% reabsorbed at the PCT level. Guys, please remember, when the reabsorption occurring, reabsorption will be occur into PCT, descending loop, ascending loop, DCT and the collecting duct. The maximum reabsorption area, if the question is asked, undoubtedly without thinking anything, you should immediately mark the option A, that is the PCT. PCT is the area where the 70% reabsorption will be occur. 100% reabsorption of the two substance, amino acid and the glucose, and remaining part is 70%. Doesn't matter whether there is a ADH or not, all the time you should mark the PCT is maximum reabsorption area in the nephron, right? Now, these two segment, they does not require for functioning any hormone, so that's why this area we called as selective reabsorption area, and this DCT and the collecting duct require the hormone for the functioning, so we call them what? That's conditional reabsorption area. If the condition is there, hormone will come and they will act. In the PCT, different channels are there. As I told you, SGLT is there for the glucose, and then there will be the sodium channel will be there. We know that in the PCT continuously metabolism is happening, so CO2 continuously producing, water is continuously producing, and due to the presence of carbonic anhydrase, they both are mixing together making the carbonic acid we called as H2CO3, which is a very weak substance. Immediately it can be dissociate into H ion and the bicarbonate. This H will be exchanged with the sodium and sodium will come inside. One positive if coming in, one positive will get out. Now this sodium will move out from this area via the sodium potassium ATPase pump and ultimately it will mix into the blood. Now this carbonic anhydrase inhibitor is called as acetazolamide, which is also the diuretic drug or the drug of choice for the mountain sickness. If this area is going to be damaged, guys, no glucose can be enter, no sodium can be enter, H will remain inside, and this condition we called as Faine-Coney syndrome. What we call this? Faine-Coney syndrome, remember, right? Now, next part is that descending loop of Henle, which is only the water permeable, and this water goes via the osmosis. So if we want to block this water, we have to give some drug we called as osmotic diuretic, and name of the drug is mannitol. Then this is the ascending loop of Henle, which contain the channel we called as NKCC. This we called as sodium potassium 2 chloride symporter. NKCC, very important, guys. If you will block, because this is only the area for the ions permeable, only ion can move inside, no water can move inside. So sodium potassium 2 chloride symporter is there. If we want to block this channel, we have to give loop diuretic, and this loop diuretic we called as furosemide. Right? If this channel is going to be defected, this condition we called as Bartter syndrome. Bartter syndrome, right? Next is DCT. Sorry. Next is DCT. In the DCT, there is the channel we called as sodium chloride channel. Guys, if this channel is going to be defected, this condition called as Gentleman syndrome, and if we want to block this channel for the diuresis, we can block it via thiazide diuretic, and the name of the drug is hydrochlorothiazide. Then last is collecting duct. In the collecting, two type of cell is there, P cell and the I cell. Guys, P cell stands for the principal cell, which is having the ENaC channel over here on the apical side, and also the ROM-K channel. ROM-K stands for renal outer medullary potassium channel, and ENaC stands for epithelial sodium channel. Guys, whenever the sodium wants to reabsorb, this will be reabsorbed via ENaC, and whenever one positive ion if coming inside from the cell, another positive ion should move outside, and this is actually your potassium, and this goes out via the ROM-K channel. Now, there is aquaporin 2 channel, which actually I already told you via functioning of the ADH hormone. Now, so whenever the potassium will move outside, H ion will also move outside, and ENaC is actually opens due to the functioning of the aldosterone. Very important. So if the aldosterone will come, then this message will go to the nucleus. Nucleus will open the ENaC, and then the ENaC opening lead to sodium reabsorption, potassium excretion. Guys, suppose ideally this ENaC should always remain closed, but if this ENaC remain open, this condition we call as Liddle syndrome, and if we want to block this channel to decrease the reabsorption of the water and the sodium, guys, the drug which we can use over here we call as potassium sparing diuretic, we call as spironolactone. So that is how the different Functionality. Now the one more thing, please remember, related to the aldosterone. If aldosterone increase very much or if decrease very much, if it is increase, this condition we call as Cohn's disease, and if it is decrease, that is we call as Addison's disease. And now you can easily understand and easily remember what is going to be happen in the Cohn's and the Addison's. Guys, please look at over here. If excessive amount of the aldosterone will be released, guys, what is going to be happen? ENaC will be open more, potassium will move out more, H ion will move out more. So guys, what the body will show? Body will show more sodium, means hypernatremia. Water will also move little bit, hypervolemia, leading to hypertension. Potassium will move out, will leading to hypokalemia, and H is actually the acidic in property. So if H ion will also move outside, body will remain alkaline. So body will show metabolic alkalosis. So that is the feature of Cohn's. Opposite condition is the Addison. In Addison, if this ENaC is not opening, ROM-K will also not open. This H ion will also not move. So what body will show? Sodium loss will be there, water loss will be there. Body will show hyponatremia, hypovolemia, hypotension. Potassium will remain inside, hyperkalemia, H ion will remain inside, metabolic acidosis. Right? Now in the Liddles and in the Cohn's, the condition looks same, because in the both condition ENaC is more open. Guys, how you can differentiate whether this is the Liddles or whether the Cohn's? Only the one indication, the level of serum aldosterone. If the level of serum aldosterone remains normal and then this condition all are happening, that is diagnosis is Liddles. But if the serum aldosterone is high and then all these conditions are showing in the MCQ, our right answer is the Cohn's disease. Right answer is the Cohn's disease. Okay. So I hope now this part is clear. Now the one quote for all of my lovely students, रास्ते पर कंकड़ ही कंकड़ हो तो भी एक अच्छा जूता पहनकर उस पर चला जा सकता है। यानी कि कितनी भी मुसीबतें आएं हम आराम से उसके ऊपर चल सकते हैं, लेकिन यदि एक अच्छे जूते के अंदर एक भी कंकड़ हो तो एक अच्छी या एक स्मूथ वेग और स्मूथ सड़क के ऊपर भी कुछ कदम तक चलना मुश्किल है। यानी कि बाहर की चुनौतियों से नहीं, हम अपनी अंदर की कमजोरियों से हारते हैं। तो गाइस, अपने अंदर यू शुड ऑलवेज बी पॉजिटिव। इसलिए मैं हर बार हर क्लास में आप लोगों से सिर्फ एक ही विनती करता हूं कि बेटा अपने आप को पॉजिटिव रखो, अपने आप को हमेशा पावरफुल रखो और अपने आप से सिर्फ एक चीज कहते जाओ, यस आई कैन डू इट एंड आई एम गोइंग टू डू इट। राइट गाइस, नाउ कमिंग टू द नेक्स्ट क्वेश्चन। What is the primary function of pulmonary surfactant in alveoli? Yes, please answer. What is the primary function of pulmonary surfactant in the alveoli? Option number A is increase lung compliance by increasing surface tension. Option B is decrease surface tension and increase compliance. Option C, decrease lung compliance. Option D, increase airway resistance. Yes. Please answer for question number 17. Yes, guys. Well done. All you are wonderfully answering. Yes. The pulmonary surfactant is actually made up of the lipid. Which two lipid? That is DPPC, dipalmityl phosphatidylcholine, also called as lecithin, and another one is sphingomyelin. For both of them we use the word LS ratio. If this LS ratio will be decreased, we call it as respiratory distress syndrome and the hyaline membrane disease, right? Hyaline membrane disease or the respiratory distress syndrome. Now, the surfactant always increase the lung compliance. It helps for the stretchability of the lungs, stretchability of the alveoli. So basically decrease the surface tension and it will always increase the compliance. And remember guys that this surfactant always increase by the steroids, and this will always decrease by insulin. So that is why to a diabetic mother during the labor we always give the dexamethasone injection. This is not for the mother, this is for the baby which is coming out after some times, so that baby's lung can be properly inflate, properly have the stretchability. So right answer of this question is option number B, that is decreased surface tension and the increased compliances, right? Now, so this is the surfactant. Remember, surfactant deficiency can show hypoxia, hyperoxia, acidosis, atelectasis, pulmonary congestion, right? And this is produced by type 2 pneumocyte cell, and this is also produced by Clara cell. So guys, if the question is asking that surfactant is mainly produced by, you should be answer type 2 pneumocyte cell, but if it is not giving in the option, then you should choose the Clara cell. Then this is degraded by, this surfactant degraded by GMCSF, which stands for granulocyte macrophaging colony stimulating factor. Granulocyte macrophaging colony stimulating factor. So this is degraded by a GM-CSF, and it stores in, laminar bodies. This stores in laminar bodies, right? Now, coming to the next question, which part of the basal ganglia circuit lesion is typically causes hemibelesmus? Yes guys, please answer for question number 18. Which part of the basal ganglia circuit lesion is typically causes hemibelesmus? Yes. Yes. So answer of this question is, yes guys, that is subthalamic nucleus. Subthalamic nucleus, what is the neurotransmitter? That is glutamate. So remember guys, hemibelesmus is the deficiency of the glutamate and the lesion in the subthalamic nucleus, right? Now, this subthalamic nucleus is below of this part is actually substantia nigra, which actually shows the Parkinson's disease. Two areas are there, pars compacta, pars reticulata. In pars compacta, there is a deficiency of the dopamine. That is the problem in the Parkinson's. That happens the Parkinson's disease. Now that caudate and putamen, guys, putamen and caudate, combinedly we call them what? Striatum. And globus pallidus and the putamen, we call them lentiform nucleus. We call the lentiform nucleus, right? Lentiform nucleus. So what are the different pathological condition and what is the basal ganglia function? So basal ganglia function, always remember, it provides the motor control, that is that procedural learning, and also for the cognitive functions, right guys? So basically this is a interconnected nucleus situated at the base, or you can say that base of the cortex nearby the thalamus, and now they all are interconnected, and whenever any motor command goes downside to the body, guys, they always facilitate via the two pathways, direct and indirect pathways. Now just remember that pathological condition of the basal ganglia. If Parkinson's, if we'll talk about, this is actually that that is in the substantia nigra in pars compacta area, and there is a defect or deficiency of the dopamine neurotransmitter, right? And now the main symptoms is the trap, there is the tremor, and this tremor is actually the resting tremor. Guys, intentional tremor will be seen in the cerebellum lesion, and the resting tremor will be seen in Parkinson's. Then there will be the rigidity, akinesia, and the postural instability. Huntington's, that is actually the affected area is the striatum. That is striatum, just now we discussed, that is the caudate and the putamen, and basically this is having that cognitive changes and the involuntary breathing movements will be there. Hemibellismus, this is actually in the subthalamic nucleus, and there is the neurotransmitter is the glutamate, and this is undesired flailing of the limbs like this, the person will move the half portion of the body like this. This we call as hemibellismus, right? So this is mainly happens in the proximal limb muscles, right? Now, so coming to the next question number 19. Question number 19, the loss of pain and temperature sensation in Brown-Séquard syndrome occurs. Yes guys, please answer question number 19. The loss of pain and temperature sensation in Brown-Séquard syndrome occurs. Yes. Ipsilateral below the lesion, contralateral below the lesion, bilateral at the level of lesion, and the ipsilateral above the lesion. So first of all, you should be identify. They are asking about the pain and temperature sensation. We discussed in the class there are the different type of sensory sensation, like there are some via the dorsal column pathways and some via that spinothalamic pathways, right? And in the spinothalamic pathways there is anterior and the lateral spinothalamic pathways, that is anterolateral pathways. Now we all know that from the dorsal column, there will be, yes, remember guys, remember the mnemonic, the story which I told in the class about this dorsal column sensations, right? That is your fine touch, proprioception, yes Mejut, very good, you remember, proprioception, vibration, tactile localization, 2-point discrimination, and stereognosis. And basically they decussate at medulla. So basically they always decussate at the level of medulla, right guys? Now the spinothalamic pathway, that is anterolateral pathway, in this anterolateral, that's from the anterior part, there will be crude touch and pressure, and via the lateral, pain and temperature, right now. So now you can see that this spinothalamic pathways, they always decussate at the level of spinal cord. It means whenever there will be the hemisection of the spinal cord, spinothalamic always affected for the opposite side, and the dorsal column which are decussating at the level of medulla, they will affect always on the same side, means that is for the ipsilateral side. So now the question is asking about the pain and temperature, and pain and temperature, this is via your lateral spinothalamic, means this is decussating at the spinal cord, and ideally they should be gone for the opposite side, right? So not for the ipsilateral, this will always go for the contralateral. So now you can see that you can apply the rule out method, no ipsilateral, no bilateral, no ipsilateral. So what is the remain? That is the contralateral below the lesion. Right guys? Now coming the next question. Question number 20. A patient presents with the flaccid paralysis, absent reflex and the muscle fasciculation. These features are most consistent with. Yes. What is the clue? The clue is flaccid paralysis. What is the clue? Clue is flaccid paralysis. Right guys? Now, that is the flaccid paralysis. Yes, so two type of paralysis we studied, spastic paralysis and the flaccid paralysis. Guys, remember that spinal reflex, the spinal reflex we studied via the GTO, Golgi tendon organ, and the muscle spindle, the sensation reaching inside the spinal cord, and then via the alpha motor neuron and the gamma motor neuron, it is coming down and basically it is activating the muscle, right? Yes, so flaccid paralysis. The flaccid paralysis, this is actually seen in the lower motor neuron lesion. For the upper motor neuron lesion, it will show the spastic paralysis. Right guys? Spastic paralysis. Spinal cord hemisection, this is your Brown-Séquard syndrome that we have already discussed. Brown-Séquard syndrome, right? Now, so just remember the upper and the lower motor neuron. That's in the upper motor neuron, everything will be more and more and more. Means more muscle contraction, spastic, more muscle tone, hypertonic, more muscle reflex, hyperreflexive, more atrophy, means disuse atrophy, and there will be the positive Babinski sign. What is the positive Babinski sign? There will be the hyperextension of the great toe, or you can say the dorsiflexion of the great toe and fanning of the remaining toe of the foot. That we call as what? Babinski sign. Then in the lower motor neuron, everything will be less. Contraction will be less, flaccid, less muscle tone, hypotonic, less muscle reflex, hyporeflexic, and less muscle innervation. And this shows negative Babinski sign. Right? So toe will be like this, and in the upper motor neuron, toe will be upside. So you can remember, like in the mnemonic, in upper motor neuron, everything will be more and more and more, and lower motor neuron, which is downside, everything will be less, less and less, right? Now, coming the question number 21. A patient presents with inability to judge distance while reaching for objects and past pointing on examination. This features is called. Yes, guys. This feature is called. Yes. What we call this feature? That is dysmetria. dysmetria, past pointing guys, past pointing. Past pointing. Remember what is the dysarthria? Dysarthria is slurred speech. Slurred speech. Ataxia is impaired balance and the coordination. Impaired balance and the coordination, and this lesion is always in the cerebellum. Lesion is always cerebellum. And then what is this rebound phenomena? Rebound phenomena means, suppose in this picture you can see, whenever you will ask the patient to flex the elbow against the resistance, you are putting the resistance like this, right? And then you will sudden release, that hand is trying to face like this. So this is what is going to be happen when आपने किसी का हाथ को यूं रोक रखा है and now you are asking him कि भैया इस हाथ को flex करो. When suddenly if you remove your hand, what will be happen? This person will hit his face. So this is we called as rebound phenomena, right? This we called as rebound phenomena, right? Because there will be delay in the triceps contraction. So this we called as rebound phenomena, and this condition when there is a inability to judge the distance, and past pointing we called as dysmetria. Coming to the next, which factor will decrease flow rate according to the Poiseuille equation? Which factor will decrease the flow rate according to the Poiseuille equation? Yes guys. Yes, please answer. Question number 22. Which factor will decrease flow rate according to Poiseuille equation? Yes. So first of all, we should understand what is the Poiseuille equation. This Poiseuille equation. Yes guys. Anybody? Flow rate कब decrease होएगा? फ्लो कब डिक्रीज होएगा किसी भी चीज का? सपोज गाइस जस्ट पुट योर माइंड, दैट्स फॉरगेट अबाउट द वर्ड्स एंड एवरीथिंग. कब फ्लो डिक्रीज होएगा? जब प्रेशर बढ़ेगा? नहीं, द फ्लो विल बी इंक्रीज. रेडियस वेसल बड़ी होगी, रेजिस्टेंस कम होगा, फ्लो विल बी इंक्रीज. विस्कोसिटी, इफ विस्कोसिटी इंक्रीज, फ्लो विल बी डिक्रीज. And if the vessel length will be shortened, immediately flow will be there. So that is how there will be the flow rate will be increased, right? So whenever we are talking about that decrease the flow rate whenever there is the increase in the viscosity, right guys? So what is the Poiseuille equation? You can see over here, this defines by the delta P. Delta P means change in the pressure, then the 8, then eta or mu, and then the L is length and Q is flow rate. Then the pi and R4, R is radius. So this is how this eta defines the viscosity, right? This eta defines the viscosity. Now the sometime question can be asked that what could be happen to the flow? What could be happen to the flow if radius double? If radius double. So guys, remember, flow is proportional to radius power 4 upon L, means the length. So how you can measure it? You can measure it if the radius is double, means this is the 2 by 4 and length remains same. So what is the answer? 2 into 2 into 2 into 2. This is the flow will be increased by the 16 times. If the question is saying length is also double, suppose length is also double, then what will be flow? Radius double and length is double, then this should be become 2. Now what will be the answer? This will also 2. So what will be answer? 16 divided by 2. So this will become 8 times. 8 times. So this is how you should calculate via this Poiseuille equation. Very, very important. Right guys? Very, very important. और बीता हुआ कल तुम्हारे दिमाग में है और आने वाला कल तुम्हारे हाथ में है, राइट? तो इस आने वाले कल को अपने को पकड़ के रखना है और अपने को और बेहतर बनाना है, राइट गाइस? कमिंग टू द नेक्स्ट क्वेश्चन. ए कंटिन्यूअस मशीनरी लाइक मर्मर बेस्ट हियर्ड एट द लेफ्ट इंफ्राक्लेविकुलर एरिया इज टिपिकल ऑफ विच कंडीशन विल शो दैट कंटिन्यूअस मशीनरी लाइक मर्मर? Yes guys. Yes, please answer for question number 23. Question number 23. Yes, it is PDA, patent ductus arteriosus. Absolutely, you are right. Patent ductus arteriosus, right, guys? Now, so what are the different conditions? We have been discussed in the class that there are the pansystolic murmur, pandiastolic murmur, crescendo decrescendo murmur, and there will be the continuous murmur. This pansystolic murmur we also called as holosystolic murmur, and this continuous murmur we also called as machinery murmur. And this machinery murmur we discussed in the class, it's seen in the PDA, right, guys? Now, so different murmurs. This ASD will be seen in systolic. ASD will show the systolic ejection murmur. VSD will show holosystolic or the pansystolic murmur, and then the correctation of iota will show the systolic murmur. So this is the different condition. This is, you can see over here, increasing gradually and then decreasing gradually. This we called as crescendo decrescendo murmur. When this is going to the upside, we called as crescendo. When it is coming to the downside, we called as decrescendo. This will be seen in aortic stenosis. Now, that continuous murmur, you can see that continuously sound is coming. Ideally, you should see the sound should come at this level, first heart sound, second heart sound, then first heart sound, second heart sound. But if the sound is coming like this continuously, we call as continuous murmur, and this will be seen in the PDA. Then the pandiastolic murmur. This is the diastolic phase, this is the diastole, this is the systole. So pandiastolic murmur, this will be seen in aortic regurgitation, right? Now, this, yes, crescendo decrescendo is also called as your diamond shaped murmur. Very good. Coming to the next question. Which of the following junction is primarily responsible for preventing paracellular movements of substance across the epithelial cell? Yes, guys, please answer for question number 24. Which of the following junction is primarily responsible for preventing paracellular movement of substance across the epithelial? Paracellular means between the two cells. Suppose this is the one cell, this is the another cell, and now they are joining over here like this, right? So now these both cells are attached together, and if any substance is passing through this area in between this gap, this we call as paracellular transport. If anything enters from one side to the cell and passes across to the another and gets out from the another side of the cell, we call as transcellular transport. तो अगर साइड से निकल जाए पैरासेलुलर, सेल के अंदर से निकल के जाए तो बोलेंगे ट्रांससेलुलर ट्रांसपोर्ट, राइट? ट्रांससेलुलर ट्रांसपोर्ट. Guys, please read the question carefully. पैरासेलुलर, ये पैरासेलुलर, यहां से कोई भी चीज पास नहीं होनी चाहिए. सी गाइस, ये जो पार्ट है, सपोज दिस इज द पैरासेलुलर एरिया, यहां से कोई भी चीज पास नहीं हो रही है. सपोज व्हाई? Because there is a very tight junction. Guys, and this tight junction is made up of occludin and claudin. So this is your tight junction. Right answer of this question is tight junction, right? Paracellular movements is prevented via the tight junction, which is also called as zonula occludens. Two proteins are there, occludin and claudin. So you can see that transcellular diffusion, something entering into the cell and getting out from the cell. Then paracellular, that is efflux system, anything that is getting out in between the cells, that is the paracellular. And the carrier mediated, which required the protein channel, and then that receptor mediated transcytosis, that is endocytosis and exocytosis, right? So different type. This tight junction prevent कि यहाँ से कोई भी चीज पास नहीं होने पाए, and this is made up of two protein, occludin and claudin. So guys, this we called as paracellular transportation. So who is preventing this paracellular transportation? Now you can see the paracellular transportation is prevented via tight junction. right guys? Now please tell me, gap junction is found where? Gap junction found in which muscle? Yes guys, gap junction is found in which muscle? Gap junction is found in cardiac and smooth muscle. Cardiac and smooth muscle. It is not found in skeletal muscle. Skeletal muscle, and this gap junction is made up of conaxial protein. Right, conaxial protein. Desmosome is cell to cell junction, and hemidesmosome cell to basal lamina junction. If this desmosome is going to be defect, this condition we called as pemphigus vulgaris, and if hemidesmosome is getting defect, we called as bullous pemphigus. Right guys? So just remember all this part, very important. That's many time, that's in the recent examination, in the different examination, that question is asked from this cell junction, right? Now coming to the last MCQ of this session, which of the following is an example of a positive feedback mechanism in the human physiology? Yes guys, in the homeostasis we studied three type of mechanism are there: negative feedback, positive feedback, and the feed forward feedback, right, which is also called as anticipatory system, right, or anticipatory feedback. So please answer for question number 25. Which of the following is an example of a positive feedback mechanism in human physiology? Yes guys. Regulation of the blood glucose by the insulin. This is actually the negative feedback. What is the meaning of negative and the positive feedback? If some changes occurs and body reverse these changes, this condition we call as negative feedback. If some changes occurs and bodies also respond in the same direction and body will also try to do further changes in the certain direction, we called as positive feedback. And if without any stimulus, due to the anticipation, body is something anticipating, and without any stimulus, and if body in advance showing some response like that temperature regulation. In temperature regulation in the cold area, whenever the body is going to be anticipate that outside is very much cold, when you are getting out, in before that you will show the shivering. Why you are shivering? So your body temperature can be increased. This we called as what? Feed forward feedback. So guys, regulation of the blood glucose is negative feedback. Blood clotting cascade activation, yes, this is ideally this should not be happen. But if whenever there is an injury, there is a stimulus, this blood clotting is going to be activate. So this is your positive feedback. Example, regulation of the blood pressure. This is again the negative feedback. Body never wants to increase the BP. If BP will be increased, body will try to decrease, and BP will be decreased, body will try to increase. So it's a opposite direction. And thermoregulation, that is could be the feed forward, right, feed forward. So examples of this different areas. Positive feedback examples like coagulation cascade, action potential, LS surge, and the parturition. This parturition means the childbirth. Then the negative feedback like the blood sugar control, BP regulation, right, right. Now if we talk about the coagulation pathway, we know that two type of pathways are there: intrinsic pathway and the extrinsic pathway. This intrinsic pathway, that is initiated by that's 12 clotting factor, then it activate to 11 to 9 to 8, and then ultimately they will activate the common factor, that is factor number 10. Then the extrinsic pathway, which is actually coming from the cell, right? Why we are calling it a two pathway, intrinsic and the extrinsic? Guys, please pay attention. This is the blood vessel and this is the cell. If any injury occurs, there can be a damage in the blood vessel. there can be damage in the blood vessel. Now this blood vessel damage will lead to what? There will be the leakage will be there. To stoppage to this leakage, immediately the platelet will become and platelet will pluck will over here, and then to repair the clotting factor will be activate. Now if any clotting factor comes from inner membrane of the vessel, this clotting factors we call them intrinsic factor. Intrinsic factor यानी कि जो वेसल के अंदर से आए हैं. एंड इफ दिस वेसल आस्क द हेल्प टू द नियर बाई सेल कि भैया मेरे से नहीं हो रहा, आप भी मदद करो मेरे को इसको सही करने के लिए. इफ द एनी केमिकल्स इफ कम्स फ्रॉम द सेल साइड, दिस वी कॉल्ड एज एक्सट्रिंसिक फैक्टर. Extrinsic factor, and this extrinsic factor is coming from the cell, hence we also called as tissue factor. भाई दो ही तो चीजें हो सकती है. अगर सेल की इंजरी ओवर देयर, दिस सेल वेसल की इंजरी इज देयर, दिस वेसल इंजरी वी नीड टू ट्रीट, we need to recover, we need to build up again. Guys, chemical is required for the messaging, and if the chemical is coming itself from the vessel, we call as intrinsic factor. If it is coming from outside of the cell, and outside of the cell is only the tissue is there, so outside of the vessel, if the any chemical is coming, this is coming from the cell, we called as the cellular factor or the tissue factor, and these are also called as extrinsic factor. How much time it is going to be take? How much time it is going to be take? If we want to check it, we can check it like in that way. If we want to check the time period of the activation of the intrinsic factor, this we done via APTT, and if we want to check the time duration of the extrinsic factor, this we can check it via PT, prothrombin time. So that is how we always check, means इस पूरे coagulation को होने में कितनी देर लग रही है, इन factors को activate होने में कितनी देर लग रही है, right guys? So all this part might be studied at many areas, but why we are calling them intrinsic and extrinsic pathway might be now you are very well understood, and nobody will forget this part, right? So this is how the common factor is factor number 10. This factor number 10 is actually always stimulated by the vitamin K. So if you will give the vitamin K, this will ultimately stimulate the factor number 10, which ultimately activate factor number 5, factor number 2, and then factor number 1, which will convert the fibrinogen into fibrin, and this fibrin will showing the this fibrin is the protein which actually helps for the reconstruction of this vessel. So that's why whenever any ladies goes for the labor, we know that after the labor, after the delivery, there will be the hemorrhage will be there. We just want to reduce the hemorrhage. This hemorrhage reducing we can be done via increasing the activity of the coagulation factors. Hence we always give the vitamin K injection in the labor time, so that already there will be the activation of the coagulation cascade, and there will be certain time should be decreased for the coagulation factor. So that's why we always suggest the vitamin K injection. So guys, I hope that now you understood many things about all of this physiology, and this is the 25 most important MCQs for this session. Now guys, few things, because now this is the last time when we are actually talking, and after that maybe yes we will talk through the other that's channel like that, from that any other the miss session or any other if session is going to be happen, from there we will meet, but right now in this session we will not meet after this part. So guys, the few things I would like to tell to each and every students. Guys, first of all, show the belief in yourself, have the courage to study well, to show that's your power to each and everyone. Might be the people will always make the bad comments on you, but you should have the courage to listen them very patiently, because the day will come when you will tell them by that's your job and by your work and by your all this hard work, not by your words. So always never ever tell any words to any people. Just try to focus on your preparation. Just try to do the hard work as much as possible, क्योंकि यही है असली ताकत. आपको उस बंदे को जवाब अपने काम से देना है, अपनी मेहनत से देना है, अपने शब्दों से नहीं. और यही वो दिन आएगा कि 26 जुलाई को आप भी इस एग्जाम को पास करेंगे, उस पीडीएफ के अंदर PASS लिखा हुआ आएगा और इस PASS को देखते ही आप सबकी आंखों में बेटा खुशी के आंसू आने वाले हैं। उस दिन के लिए इस 1 महीने के अंदर जुड़ जाओ और इस 1 महीने को ऐसा पढ़ो, ऐसा पढ़ो, ऐसा पढ़ो कि बस हर कोई उस 26 जुलाई के बाद में आपके लिए इस हाथ को सिर्फ यूं उठाए और सिर्फ सलाम करे। कौन कहता है कामयाबी किस्मत तय करती है, इरादों में दम हो तो मंजिलें भी झुका करती है। और ये जो हैंड आज आप देख रहे हैं, द हैंड यू आर सीइंग ओवर हियर, दिस इज नॉट ए सिंगल हैंड, दिस इज द हैंड ऑफ द FMGs, दिस इज द हैंड ऑफ द FMGs unity, and this FMG can do anything in India and in outside in India. That's the power of the FMG. Show the power to each and everyone guys, और फोड़ दो, आग लगा दो और लोगों को कहने दो कि भैया ये जो FMGs हैं, क्या इन लोगों के अंदर जान है, कितनी ये मेहनत करते हैं। सर लोगों को करके दिखाना है और ऐसा करके दिखाना है कि ये हाथ हमेशा अपना उठा रहे और लोगों का हाथ हमेशा अपने को सलाम करता रहे। जय हिंद, जय भारत। I am Dr. Arun Swami. Guys, wish you all the best for your upcoming FMG examination. Thank you guys. Thank you very much for taking this session. I hope this session helped you a lot. And if you have any question, any doubt, my number are with you. You can message me, you can ask me. So stay blessed, stay motivated and keep studying guys. Thank you very much.